Welcome, everyone. Today we are going to be discussing depressive and bipolar disorders. We're going to talk about the clinical descriptions and the etiology of these mood disorders, the symptoms, and the treatment. Today we are going to begin by discussing the clinical descriptions and diagnostic classifications for depressive and bipolar disorders. These categories are divided into disorders involving depressive symptoms and those characterized by manic symptoms. Disorders involving manic symptoms are classified under the bipolar disorder category. For depressive disorders, we are going to be focusing on the DSM-5 depressive disorders, including major depressive disorders, persistent depressive disorder, also known as PMDD, or dysthymia, it's also been called, premenstrual dysphoric disorder, PMDD, which is a new addition to the DSM-5, and then disruptive mood dysregulation disorder, DMDD. And then we're going to talk about bipolar disorders, which we are going to cover 1, 2, and psychothymia. This is a brief overview of the DSM-5 mood disorders and their key features. Think of this as a roadmap to help you understand what we're going to be covering today. With MDD, Major Depressive Disorder, that involves 5 or more depressive symptoms, including a sad mood or loss of pleasure, lasting at least 2 weeks. I like to think of it as 2 blue weeks. That's a good way to remember it. Persistent depressive disorder extends the time frame to 2 years or more of depressive symptoms. So that's going to be a key distinct and defining feature there. Premenstrual dysphoric disorder, characterized by mood symptoms that occur in the week before menstruation. It's kind of in the title there. So to diagnose PMDD, clients would need to track both their menstrual cycle and their mood fluctuations. Disruptive mood dysregulation disorder is defined by severe recurrent temper outbursts and persistently negative mood lasting at least 1 year with the onset before age 10. Bipolar disorder requires at least 1 lifetime manic episode. Bipolar 2 disorder involves at least 1 lifetime hypomanic episode along with depressive episodes. And then for bipolar 2, mood changes do cycle from highs, whether that is a hypomanic episode, to a low, which is the depressive episode, over a period of at least 2 years. Excuse me, this is psychothymia. This cycling pattern is important characteristic to keep in mind as we explore these disorders. We're going to begin with MDD, Major Depressive Disorder, and as we delve into its specifics, it is defined by a sad mood or loss of interest or pleasure. Whenever we say that, it's also the same as anhedonia. That lasts for at least 2 weeks. These symptoms must be distinct from and more severe than a normal response to events such as grief. In addition to a sad mood or loss of interest, you need at least 4 of the following symptoms: sleeping too much or too little, psychomotor retardation, meaning very slowing down, or agitation, that would look like kind of physical restlessness, um, poor appetite and weight loss, or increased appetite and weight gain, loss of energy, persistent fatigue, feelings of worthlessness or excessive guilt, difficulty concentrating, paying attention, or making decisions, and recurrent thoughts of death or suicide. So these symptoms combine to create a significant disruption in daily functioning that go beyond what would be typically expected in response to a stressor or a loss. When considering the diagnosis, it's important to note the following: that these symptoms tend to dissipate over time, though they may recur, so they're episodic in nature. Can be a recurrent pattern, so once an individual experiences an episode of depression, they are more likely to have additional episodes in the future. Average number of episodes is 4. And then with regard to frequency, on average, individuals experience multiple depressive episodes over their lifetime. It is worth noting that clinical depression can manifest as sadness, accompanied by at least 3 other symptoms lasting for approximately 10 days. And that has significant impairments in functioning, even though the full criteria is not met. Now we're going to review the criteria for persistent depressive disorder, PDD. Think about this on a continuum, and this continuum moves from the least intrusive to the most intrusive aspect of one's life. This person may initially have depressive symptoms that don't meet criteria for major depressive disorder. Over time, they may meet criteria for MDD. And then if the depressive symptoms persist for at least 2 years, And if it's for children and adolescents, it's only 1 year. The diagnosis transitions into persistent depressive disorder. So, some key features are going to be depressed mood lasting at least 2 years in adults and 1 year for children or adolescents. And they have to have at least two additional symptoms, which may be changes in appetite, too much or too little, sleeping, too much or too little, low self esteem, difficulty concentrating or making decisions, and then feelings of hopelessness. Additionally, these symptoms cannot clear for more than 2 months at a time. So it's important to note that bipolar disorders have to be ruled out first before being able to diagnose something like PDD. A common diagnostic challenge in differentiating persistent depressive disorder from major depressive disorder. For instance, when you meet a client, you may not have enough data to confirm their symptoms have persisted for 2 years. So, in such cases, it's appropriate to initially diagnose major depressive disorder or some type of episodic depression, and then revise the diagnosis later if you get more consistent long term data that emerges. And this highlights the importance of recognizing that diagnoses can evolve over change as more information does become available to you. Next, we're going to discuss the DSM criteria for premenstrual dysphoric disorder. If it feels like we're moving quickly, don't worry. Once we cover the basics, we're going to explore the etiology, the neurological factors, and the specific treatments for PMDD. So, to meet this criteria, symptoms must occur during the luteal phase of the menstrual cycle and must be present in most menstrual cycles throughout the year. Additionally, at least five of the following symptoms must be present: mood liability, so sudden mood swings or tearfulness, irritability or anger, depressed mood or self deprecating thoughts, high anxiety or tension, diminished interest in usual activities, difficulty concentrating, fatigue or low energy, changes in appetite, overeating or having cravings for food, sleep disturbances. This could also look like too much or too little, a subjective sense of being overwhelmed or out of control, even if others don't perceive this. And then physical symptoms. This could be breast tenderness, swelling, muscle pain, bloating, or weight gain. So these symptoms cause significant distress or they interfere with daily functioning to warrant the diagnosis of PMDD. All right, now we're going to see the criteria for disruptive mood dysregulation disorder, DMDD. And this slide does have a lot of information on it. We're just going to look at some key points. Some core features of DMDD is that it's characterized by recurrent severe temper outbursts, which typically occur 3 times or more per week. These outbursts are accompanied by persistently negative mood on most days. Duration: these symptoms must be present for at least 12 months without a period of more than 3 months symptom free. With regard to age of onset, this disorder is diagnosed in children age 6 and older, with symptoms starting before the age of 10. It is most commonly diagnosed between the ages of 6 and 10 years old. Some exclusions: the child must not have experienced a distinct period lasting more than 1 day in which they exhibited elevated mood, along with at least 3 other manic symptoms. So, we want to rule out mania, basically, is what we're trying to do there. The behavior should not occur exclusively during another major depressive episode. The symptoms cannot be better explained by other conditions like ADHD, intermittent explosive disorder, or bipolar disorder. DMDD often overlaps with other disorders such as conduct disorder or depression, making it essential to carefully distinguish between these conditions during diagnosis. Let's consider some key clinical considerations regarding the set of these disorders as we transition further into discussing their causes. Clinical depression is incredibly common, as you are likely to encounter it frequently during your experiences in becoming a counselor. And here are some important statistics to keep in mind. The lifetime prevalence of clinical depression in the general population is about 16.2%, with a 2.5% of individuals experiencing dysthymia. Depression is twice as common in women as in men, and 3 times as common among individuals who are living in poverty. This brings us to the role of Maslow's hierarchy of need. Access to resources and basic stability can significantly influence mental health outcomes, and the prevalence of depression does vary across cultures, highlighting the importance of environmental and cultural factors. For example, the prevalence of major depressive disorder is about 1.5% in Taiwan, but about 19% in Beirut, Lebanon. Additionally, individuals who immigrated to the United States from Mexico have lower rates of depression compared to individuals of Mexican descent born in the United States, illustrating how clinically and environmental shifts can impact mental health. So, these variations emphasize the importance of adopting a biopsychosocial perspective when understanding and treating depression, and just being very well versed in cultural competence. So let's continue to move on and look at the epidemiology and cultural influences, focusing on how symptoms of depression can vary across cultures and other factors. So, continuing here, in some cultures, individuals may express depression through physical symptoms rather than emotions. For example, in Latino cultures, depression may manifest instead as nervousness or as headaches. In Asian cultures, you're more likely to see symptoms such as weakness, fatigue, or difficulty concentrating. Even when the diagnosis of depression is the same, the symptoms are expressed very, very differently depending upon cultural norms and experiences. Now, geographic and environmental factors. Depression rates can vary depending upon the proximity to the equator, the length of daylight, and their dietary habits. So, these are all really very interesting. The regions with longer daylight hours and higher fish consumption tend to have lower rates of major depressive disorder. Very interesting. As we look at symptom variations across the lifespan, in children, depression often presents with physical complaints such as frequent stomach aches, headaches, general fatigue. Younger children may lack the words to describe their emotions, making their depression harder to identify. When we talk about older adults, depressive symptoms may look like distractibility or forgetfulness, which can sometimes be mistaken for cognitive decline or dementia. Remember, pseudodementia, that's going to be something that you're going to need to rule out. Comorbidity, depression and anxiety are closely related, with about two-thirds of individuals diagnosed with major depressive disorder also meeting criteria for some type of anxiety disorder at some point in their life. These two conditions are often referred to as close cousins due to their frequent co-occurrence and overlapping symptoms. Understanding these variations is essential for providing culturally sensitive and developmentally appropriate care to individuals experiencing depression. Here, this chart is going to help you visualize the differences in age of onset, and it's going to just give you a better perspective. So, as we can see here, the top line that looks like gray is ages 18 to 29. The yellow shade is ages 30 to 44. The orange shade is 45 to 59. And then the blue shade is 60 years and older. So, this breakdown allows us to see the onset of mood disorders that vary across different age groups. And you're going to review this information, so consider how these patterns might influence your work as a counselor. Understanding age-related differences in onset and presentation can help you better tailor your approaches to your clients with various different age groups. And we're also going to apply a very similar consideration when we talk about bipolar disorder and its unique age-related patterns as well. So, moving on to bipolar disorder, there are three forms of bipolar disorder that we're going to discuss: bipolar 1, 2, and psychothymic disorder. The defining feature of each is the severity and the duration of manic episodes, and that's how we're going to differentiate one from the other. Bipolar disorder typically involves episodes of depression, alternating with manic or hypomanic episodes. Mania is characterized by an elevated or irritable mood, while hypomania is a less intense form of mania. That's why we use the term hypo. So, hypo means below, and hyper means above. So, whenever we're talking about the intensity level of something, hypomania would look like mania, but a lower form of, or a less intense form of mania, if you will. So, whenever someone is in a hypomanic state, it will cause impairment, but not nearly the same significant impairment that a manic episode would cause. So, hypomanic episodes are often harder to assess than manic episodes just because they are milder in nature. Okay, let's talk more about this. I know that the font on this slide is very tiny. I apologize for that. But we're going to compare and contrast the two episodes of mania and hypomania. So, for both episodes, there must be an elevated or irritable mood for most of the day, nearly every day, along with abnormally increased activity or energy. Additionally, at least three of the following symptoms must be present, representing a notable change from the individual's baseline. So, that could be increased goal directed activities, rapid or pressured speech, flight of ideas, reduced need for sleep, distractibility. For a manic episode, the symptoms must last at least 1 week. The way that I remember this is one fun week, and that can cause significant impairment. And the person may even require hospitalization, or they may even present with psychosis. So the episode leads to a noticeable dysfunction or distress, and it can very significantly disrupt one's daily life. Now, as we're talking about hypomanic episode, this is going to last for about 4 days. There will be a clear change in functioning, which will be noticeable to others who are close to the person, especially friends and family. However, the impairment is not severe enough to require hospitalization, and there are no psychotic symptoms. Okay, so let's continue to push on here. And when we look at bipolar 1, that's going to require at least one manic episode to be present. A manic episode is defined by the characteristic symptoms of mania, as we just discussed in our last slide, that's going to cause significant distress or impairment. Bipolar 2, it requires at least one depressive episode and at least one hypomanic episode. In this case, individuals experience episodes of hypomania rather than full-blown mania. If they do meet criteria for mania, then we must change the diagnosis to bipolar 1. Psychothymic disorder is another form of bipolar disorder. It is characterized by a milder and a more chronic form. In psychothymia, individuals experience numerous periods of hypomanic and depressive symptoms that do not meet full criteria for either mania or a major depressive episode. So these symptoms must last at least 2 years in adults and 1 year in children, with no period of symptom-free duration lasting more than 2 months at a time. Although the symptoms do not meet full criteria for mania or major depression, it still does result in significant stress or impairment in the individual's life. So let's talk about some consequences related to epidemiology and etiology of mood disorders. While we've covered prevalence rates for major depressive disorder, bipolar disorder is diagnosed less frequently. This may be due to several factors, including the stigma associated with seeking treatment for bipolar disorder. Many individuals may avoid seeking help out of fear of being negatively judged. The prevalence of bipolar disorder in the United States is around 0.5%, while worldwide prevalence is about 2% according to the World Health Organization. The prevalence of psychothymic disorder is estimated to be about 4% globally. The average onset of bipolar disorder is usually about in a person's 20s, and there's no significant gender difference in the overall rates of this disorder, although women do tend to experience more depressive episodes and have more severe episodes than men. Recent research has shown that although the gender gap in bipolar disorder diagnoses is minimal, women may experience more frequent depressive episodes. In addition, research highlights that almost 1/3 of individuals who are unemployed remain so 1 year after hospitalization if they have been hospitalized multiple times due to bipolar disorder. This disorder also carries an exceptionally high rate of suicide, which underscores the importance of crisis intervention and one key reason why it's so important to have these skills in your toolbox as a clinician. Here we have a chart that highlights the different types of mood disorders and their identifiers. You'll notice terms like seasonal pattern, rapid cycling, mood congruent psychotic features, mood incongruent psychotic features, catatonia, melancholia, atypical, peripartum, and postpartum. These are all subtypes that can apply to both major depressive disorder and bipolar disorder. This chart is going to outline each of the subtypes, clarifying whether it is relevant to major depressive disorder or bipolar disorder. This chart is designed to give you a clear understanding of these subtypes and how they fit within the diagnostic criteria. So you can check this out even more. Feel free to pause the video, but we're going to continue moving on to talk about factors that contribute to the onset and the etiology. When we discuss the concept of genetic predisposition, being influenced by environmental factors or other stressors, we're exploring how these elements contribute to the onset of diagnosis of mood disorders. Both biological and psychosocial factors play a role in this process, and understanding how they interact is crucial in diagnosing and understanding the development of these conditions. Today, we will discuss the genetic factors and their role in the mood disorders. Research estimates that 37% heritability rate for major depressive disorder and a 93% heritability rate for bipolar disorder. So, this highlights a very, very strong genetic component, especially for bipolar disorder. There is significant research aimed at identifying specific genes linked to these disorders. For example, studies have suggested the DRD4.2 gene, which involves dopamine regulation, and it may be associated with major depressive disorder. Dopamine plays a crucial role in several mental health conditions, including its connection to the dopamine hypothesis in schizophrenia. So, as we continue to advance in genetic testing and neuroimaging, we're likely to see even more insights into genetic influences as science continues to evolve. Here we've got another chart, and this is going to be very useful as we understand the biological hypotheses related to major depressive disorder and bipolar disorder. These hypotheses focus on the neurobiological contributions to both. As we discussed earlier, bipolar disorder has a very high heritability rate at 93%, indicating a very strong genetic influence. For both disorders, there are several other key biological factors involved, including serotonin and dopamine. Both are present for major depressive disorder and bipolar disorder, playing a role in mood regulation. Cortisol regulation is another factor, as cortisol is produced in response to stress and is involved in both disorders. Changes in the activation of brain regions related to emotion are relevant. Additionally, activation of the striatum, an area of the brain involving the reward system, is significant. The opioid system also plays a role. It is low in major depressive disorder, contributing to a lack of pleasure or reward. In contrast, it's high in the bipolar disorder, which may explain the heightened mood or energy during manic episodes. So, hopefully, this provides a more clear understanding of some of the biological factors of these disorders. Now, for years, we've believed that neurotransmitters were the sole explanation for mood disorders. The models focusing on norepinephrine, dopamine, and serotonin levels. These models suggest that measuring neurotransmitter levels could definitely determine whether someone had a mood disorder. However, researchers later discovered that while neurotransmitter levels may fluctuate in the brain, it does take 2 to 4 weeks or even sometimes longer for medication to show effect in the patient. And this has led to a shift in how we understand mood disorders and the treatment process. New models now emphasize the sensitivity of postsynaptic receptors in addition to neurotransmitters themselves. This suggests that it's not only just about balancing neurotransmitter levels, but we also need to consider how the brain communicates and how sensitive those receptors are. For example, dopamine receptors may be overly sensitive in borderline personality disorder, but underactive in major depressive disorder, contributing to a different reaction and symptoms between these two disorders. Additionally, tryptophan, a precursor to serotonin, found in foods like turkey. However, you would have to eat a very, very significant amount of turkey in order to truly make a difference. Tryptophan does play a key role in mood regulation. A lack of tryptophan can trigger depressive symptoms in individuals with a personal or family history of depression, and as these may be more vulnerable to a depressive episode under these conditions. So, let's talk a bit more about some brain imaging. So here we're going to look at a visual representation of the dopamine and serotonin pathways in the brain. You don't need to know all this to be able to be an effective counselor, but it's going to allow you to normalize the client's experiences and just give you more depth and breadth to your knowledge. In this diagram, you're going to see the serotonin pathway leading to the prefrontal cortex and the dopamine pathway that feeds into the limbic system. The dopamine pathway is particularly important in understanding the reward system, the brain's way of processing things that feel good. And this concept also ties into the way that certain drugs impact neurotransmitter activity. Here we have another diagram, and this is showing the drug action on neurotransmitters, specifically explaining how some things like antidepressants work. In this diagram, we see the presynaptic neuron, and it's releasing serotonin, which is being taken back in by the serotonin reuptake inhibitor, or excuse me, the serotonin reuptake transporter. And antidepressants such as tricyclic antidepressants, SSRIs, these are going to work similarly by inhibiting the reuptake process, thereby increasing serotonin levels in the synapse. The communication between the presynaptic and the postsynaptic neurons plays a critical role in mood regulation by preventing the reuptake of serotonin. Medications help maintain higher levels of serotonin in that synaptic space, which improves communication between the neurons. Again, there's a lot of details here, and we're really getting into the weeds. You may not necessarily need to know this as a counselor, but you can then use this information that you're learning to confidently explain to the client how antidepressants are effective because they influence the communication between neurons by impacting serotonin levels. All right, so in this diagram on the left, we're going to see a lack of serotonin in the presynaptic neuron, while on the right, the serotonin is held in the synapse, which is where the communication then improves. So by understanding this, this can be helpful when considering whether to refer a client to a prescriber, a psychiatrist, a primary care physician for medication, as that emphasizes how medications can enhance brain communication. All right, let's break things down and make it easier to understand. When we look at brain imaging, particularly structural studies, we can see that there are differences in brain structure associated with mood disorders. And here we have a chart that's going to illustrate how different brain regions are affected by depression, mania, and other mood disorders. For example, we see in depression areas like the anterior cingulate cortex have elevated levels of activity, while in mania, those same areas show increased activation. The same pattern applies to the prefrontal cortex, the hippocampus, and the amygdala. These regions show diminished activity in depression, while activity can be elevated in mania depending upon the specific mood disorder. It's important to note that brain regions involved in depression and bipolar disorder show many similarities, which is why the disorders are often grouped together. The anterior cingulate cortex, the prefrontal cortex, and the hippocampus are particularly affected in both of these conditions. So, understanding these differences is helpful when we talk to our clients about experiences, and it provides context for their symptoms, highlighting how mood disorders can be linked to changes in brain structure and function. Let's look at some social factors. Research shows that life events play a significant role in individuals developing depression. Studies have found that between 42 and 67% of people report experiencing a stressful life event within the first year before the onset of depressive symptoms. These events could include situations like a romantic breakup, the loss of a loved one. This finding was replicated in 12 studies across 6 countries, first reported in 1989 and again 20 years later. And I would put money on it that we would continue to see the same patterns as it continues to be replicated on and on. Another important factor is the lack of social support, which can also contribute to depression. Personal difficulties and high levels of expressed emotion from family members, such as criticism or over-involvement, can predict the onset of depression or the relapse of a mood disorder. For example, if there's a lot of conflict in the household, individuals are more likely to experience depressive episodes or a bipolar relapse. Marital conflict is another common trigger that can add to the biological and psychological components of a mood disorder. Behaviorally, when someone is depressed, their actions may unintentionally perpetuate their isolation. For instance, depression often leads to behaviors that amplify symptoms and make the onset of depression last longer. These include withdrawing from social situations, excessive reassurance seeking, displaying few positive facial expressions, engaging in negative self talk, and speaking slowly. Such behaviors can result in unintentional social rejection, which in turn can worsen or trigger depressive symptoms. These are some things that we may see in our clients, and we may explore with them to really better understand the interaction between their social environment and their mood disorder. So we're going to continue to go into depth here for social support, neuroticism, and cognitive theories. Starting with neuroticism, this refers to the tendency to respond with heightened negative emotions, often perceiving situations as worse than they actually are. And this trait has been shown to predict the onset of depression. Additionally, we must examine cognitive theories such as hopelessness theory and rumination theory. The negative triad in Beck's theory involves the view of the self that creates negative schemas, which then influence how we respond to life situations, often leading us to perceive things as worse than they are. The hopelessness theory suggests that depression is triggered by a belief that there is no hope or no way forward, and that desirable outcomes will not occur. This theory emphasizes the attributional style, in which stable and global attributions contribute to feelings of hopelessness, reinforcing the belief that one cannot change their situation. And then the rumination theory, developed in 1991, proposes that individuals with depression tend to repetitively focus on sad thoughts, which worsens their emotional state. In some more in someone who ruminates on negative events, the more they amplify their depression. So, in Beck's theory, we see that negative schemas and cognitive biases feed each other, creating or intensifying depression. Here we can see Beck's theory of depression just in a chart format. In the context of the hopelessness theory, the negative life events occur, the individuals tend to make stable and global attributions about the event, believing that it reflects a permanent and all encompassing situation. This perspective leads to a bleak outlook on the future, where there is no hope for improvement or change, and as a result, factors such as low self esteem interact with this sense of hopelessness, reinforcing it and making it a central element of depression. Here are several other factors to consider when it comes to triggers of depressive episodes and bipolar disorder, which often overlap with those of major depressive episodes. These include negative life events, negative thought patterns, expressed emotion, and a lack of social support, all of which we've discussed. In addition, predictors of mania can include heightened reward sensitivity in the brain, disruptions in sleep patterns. For instance, when a person begins to experience sleep disturbances, whether that's too much or too little, or becoming restless, it may indicate a manic episode is approaching. Let's talk about treatment of mood disorders. There are various different types of treatment and therapy used for mood disorders. In the short term, psychodynamic therapy focuses on current relationships and emotional patterns. Cognitive therapy focuses on automatic negative thoughts and aims to replace them with more neutral or positive alternatives. Rational emotive behavior therapy, REBT, emphasizes challenging irrational beliefs. Mindfulness based therapies, such as mindfulness based cognitive therapy, MBCT, integrates techniques like meditation to prevent relapse and promote self awareness. Behavioral activation therapy encourages increased positive experiences through reinforcement to break the cycle of depression. Behavioral couples therapy addresses communication and relationship satisfaction to help prevent depressive relapses. Psychoeducation focuses on essential knowledge to help clients and their families. And then family focused treatment involves working with both individuals and their families to improve coping and reduce relapse. So here's just a little bit more. Again, we're going to be looking to work with family and friends and spouses whenever we treat the system, because we really do want to have a positive outcome and help the person from all aspects where we possibly can and prevent relapses as much as we possibly can. In addition to medication, there are other treatment options for mood disorders. Electroconvulsive therapy, ECT, and transcranial magnetic stimulation, TMS, are both options for an individual. ECT may seem a little outdated, but it's actually still very much used, and actually one of our most useful and effective tools when it comes to very severe um, treatment resistant depression and bipolar disorder when they're just unresponsive to medication or therapy. So during ECT, a controlled brain seizure is induced, resulting in temporary loss of short term memory. Although the exact mechanism of ECT is unclear, it has proven to be very, very effective for patients who have not responded to other treatments. TMS is another alternative. It uses electromagnetic coils placed on the scalp to stimulate specific areas of the brain. This method is primarily used for those with depression who have not responded to traditional treatments. TMS involves repetitive sessions over several weeks, and although effective, this does require time to show the results. New research is constantly emerging, and TMS is also being studied for its effectiveness in treating PTSD and other disorders. So, when it comes to medication, which is commonly used in clinical settings with a psychiatrist or maybe a PCP, the main categories are antidepressants and mood stabilizers. Antidepressants are typically prescribed for depressive disorders, while mood stabilizers are for bipolar disorders. Antidepressants are divided into several different categories. So, we may have the MAOIs, the MAO inhibitors, as they're also known, tricyclic antidepressants, and SSRIs, which are selective serotonin reuptake inhibitors. Some of the generic names you may encounter in practice, along with their brand names, include medications in these categories. Mood stabilizers, such as lithium, are commonly prescribed for bipolar disorder. Specifically with lithium, there can be concerns about toxicity at high levels, so the individual would need to have blood work done as they are beginning to be on lithium until they are stabilized for quite a while, and then the amount of monitoring can be reduced a bit because we really want the lithium to be in a safe range. Without proper monitoring, these medications can cause harm. Additionally, very important is going to be antipsychotics. Sometimes these are used alongside with either antidepressants or mood stabilizers, depending upon the severity and the nature of the condition. Research on treatments for mood disorders shows that combining therapy with antidepressants increases the likelihood of recovering up to 10 to 20% compared to using either treatment alone. Cognitive therapy, in particular, has been found to be effective as medication for severe depression and can also help to prevent relapse. This highlights the importance of integrating both therapeutic approaches and medication for the best possible results in treating depression in our clients. To wrap up, lithium is effective for about 80% of patients, offering significant relief, but it can have potentially serious side effects, including toxicity, as we've just discussed. There are some other medications that are not necessarily mood stabilizers. Instead, they actually fall under the category of anticonvulsants, one of which that you see here on this slide is Depakote. But there may be other things that we could potentially be using to combine to really get the best possible effect. An antipsychotic such as Abilify. Again, these medications come with side effects, but it's going to be crucial to really understand the individual, what they're experiencing, and working with them now, not necessarily as a counselor, but you can help them kind of put their experiences into words and coach them on how they may discuss these things with their prescriber. And you can really help normalize their experience and guide them to get appropriate care. So, we're going to wrap up here with some crisis and suicidality slides. Suicidal ideation refers to thoughts about wanting to end one's own life, while suicidal intent involves specific behaviors and actions aimed at carrying out that desire, such as taking pills or using carbon monoxide from a car. A completed suicide is when someone deliberately ends their own life through inflicted injury. Non-suicidal self-injury, on the other hand, involves harm like cutting, burning, or skin picking without the intent to die. There's also a distinction in terminology used today. Traditionally, the term quote unquote committed suicide used to be very common, but now it's often preferred to say something along the lines of died by suicide. Particularly, this language comes from organizations such as the American Foundation for Suicide Prevention, and this shift reflects a more compassionate understanding of suicidality, recognizing that individuals who take their own lives may be experiencing overwhelming circumstances and are often not in a rational mindset when they make that decision. This change in language is intended to reflect the complex biopsychosocial factors that contribute to suicidality and avoid stigmatizing individuals who are struggling. Some key clinical considerations regarding suicide include the fact that the suicide rate in the United States is approximately 1 per 10,000 in a given year worldwide. Though this can vary, globally, about 9% of individuals report having suicidal ideation at least once in their lifetime, and 2.5% have made at least one suicide attempt. As we can see here, men are 4 times more likely than women to kill themselves. Women are more likely than men to make suicide attempts that do not result in death. Guns are by far the most common means of suicide in the United States at about 60%, and men usually shoot or hang themselves, whereas women are more likely to use a method such as pills. Suicide rate has increased in folks who are of more advanced age, with the highest rates of suicide in the United States are for white males over the age of 50. The rates for suicide in adolescents and children in the United States are increasing dramatically, and being divorced or widowed elevates one's risk of suicide by about 4 to 5-fold. Here's some more risk factors for suicide. It's important to remember that risk factors increase the likelihood of an event occurring, but they do not guarantee it. For example, being overweight and not exercising may increase one's likelihood of experiencing a heart attack, but it does not mean that it will cause a heart attack or that a heart attack is inevitable. Similarly, risk factors for suicide raise the likelihood of suicidal behavior, but are not direct causes. Some key risk factors for suicide include psychological, neurobiological, and social factors. Depression is often a contributing factor, and neurobiologically low levels of serotonin and an overly reactive HPA, which stands for hypothalamic pituitary adrenal axis, have been linked to suicide attempts, which occur in about 48% of cases. Social factors such as economic recessions, media reports on suicide, social isolation, or the lack of social connection plays a very significant role in elevating suicide risks. Then we've got psychological issues here, the psychological model, which could be problem-solving deficits, hopelessness, low life satisfaction, and impulsivity are all notable risk factors. These factors don't cause suicide, but again, they may increase the likelihood of an individual engaging in suicidal behavior. As we continue to move forward, I want to talk about a couple of myths regarding suicide and how they contribute to addressing suicide head on. These myths often contribute to misunderstandings and can hinder effective intervention. So, first of all, we have people who talk about suicide actually go through with it, when in reality, talking about suicide can be a way for someone to ask for help. People often express suicidal thoughts as a cry for assistance, and it's crucial that we listen and take those expressions very seriously. Our next myth is that if a suicidal person wants to die, there's nothing that you can do about it. In reality, this is not the case at all. While suicidal individuals may feel as though they cannot find another way out of their pain, there's always something that we can do to help them through support, listening, problem solving. We can help address the pain and try to find solutions to their struggles. Another myth: if someone attempts suicide, they will always have suicidal thoughts. Again, the reality here is that this is not true. Some individuals who attempt suicide may not experience suicidal thoughts again, especially if the underlying triggers are effectively addressed and treated. Our next myth: asking someone if they want to kill themselves will encourage them to attempt suicide. This is a big fat myth. This is a very common misconception, and one that I held back when I was a student. The best approach is actually to ask directly about one's thoughts on suicide. Being open, being direct, having that communication is essential to get the right support. And we want to actually use the word suicide. There's research out there to show that when we ask about suicide and we ask directly and openly, that we are not going to put those thoughts in someone's head. And our last myth on this slide is that a good, stable relationship prevents suicide. While supportive relationships are wonderful and they're important, suicide is a very complex issue that is often dynamic. It often involves many different factors, and it may have while you may be a supportive presence in someone's life, there's usually a combination of psychological, social, and biological factors. So, a strong relationship is unfortunately not a cure all. It will be very important for loved ones to understand that they shouldn't blame themselves when someone they care about is struggling with suicidality. So, when we address myths like this, we can better understand and support individuals who are at risk and help reduce the stigma around keeping someone safe. All right, so how do we prevent suicide? What starts with open and matter of fact discussing, normalizing the fact that people experience suicidal thoughts. It's important to recognize that suicidal ideation is often linked to mental health disorders, and as a mental health provider, we play a very critical role in addressing and treating these tendencies. Our ongoing efforts in suicide prevention and training are going to be key to providing the necessary support for individuals who are at risk. One training that I really enjoy and I highly encourage folks to go to is called ASSIST, Applied Suicide Intervention Skills Training. It's a 2-day training, and I just can't speak highly enough of it. So that's what we've got for today's lecture. Thank you for your time and attention, and I'll see you in the next one.